There's also another really exciting project, pilot study that's coming up at Levine Cancer Institute that I know you think and theorize as a researcher that in the long run, you hope that it will really impact how patients are treated. So I'd love for you to give us the skinny on this project. I know you're really, really excited about it.
We are working on developing a custom liquid biopsy technique specific to sarcoma. If you're not familiar with what a liquid biopsy is essentially taking a sample of a bodily fluid, most commonly blood, although it could also be saliva or cerebrospinal fluid, and evaluating it to try to understand information about somebody's cancer. It's able to tell us, for instance, if a disease has come back, so post-treatment surveillance or for disease recurrence. It's able to give you information at the time of diagnosis about a certain susceptibility to treatment, and that's been proven true in lung cancer, where liquid biopsy detecting a certain mutation tells physicians that that patient can be treated with a certain medication and it will actually improve their survival. It can be used to, it actually can provide more comprehensive information about a tumor's genome than a regular old biopsy. And the reason for that is because tumors are heterogeneous. One part of a tumor may actually have mutations that a different part of the tumor does not have. And the liquid biopsy actually can gather a global perspective on what is happening inside of a cancer's genome. A benefit of it is that it's less invasive. A sample of blood is easier to obtain than a tissue biopsy. So, one of my goals in the research that I do is to be an advocate for sarcoma. These are rare diseases, and there's, some people say 80, some people say over 100 different subtypes that have been characterized. And so while there's a number of centers that are performing ongoing clinical trials trying to evaluate for new drugs or new combinations of drugs that can help these patients, unfortunately, the numbers of patients that are included are small, and oftentimes they include multiple sarcoma subtypes. So if they don't find anything in the study, is that a result of, having a couple different tumor types that fundamentally have a different biology? And maybe it worked for some, but not for others. It's kind of hard to tell, especially because of how rare sarcomas are. So we do need better preclinical models to try to understand what medications may work for certain sarcoma types. So I think this is an early step in working towards that. Our idea is going to be, we're going to start with a smaller pilot study of hopefully 20 or so patients, but we're identifying a custom technique in order to be able to detect evidence of sarcoma in somebody's blood. And I think this really could change the way that we treat patients. Right now, for post-treatment surveillance, patients often get CT scans every 3 months for a couple of years, and then we space it out from there, but it's a lot of radiation. What if we could reduce the frequency of CT scans by having blood tests in between? Or sometimes on a CT scan, somebody has a nodule that's, a few millimeters in size. We as physicians don't know how to interpret that, so we just say, well, let's just get another CT scan in 3 months. But what if we had a blood test that could actually give us a hint if that actually was cancer? We could treat it sooner. The problem is there are a number of commercial businesses right now that offer liquid biopsy techniques for more common cancers like blood cancers or other solid tumors, and unfortunately the techniques aren't specific to sarcoma. This is something that I really became interested in right when I started my position here, because at LCI we do work with a lot of these different commercial sequencing organizations, and I think it is very helpful for a lot of the different types of cancer patients that are seen here. But in sarcoma, the techniques just aren't quite specific, and I think they miss a fair number of patients. So I've spent a lot of time with Nuri Sturwald over in the molecular sequencing core, and we're essentially designing from scratch a custom strategy in order to identify blood evidence of sarcoma. So I'm really excited for what this could offer. In addition to disease surveillance, this could tell us about response to treatment. Wouldn't it be nice to know if we put somebody on chemotherapy, if it's not working? We could potentially understand that better. can we tell, based on disease burden, if that correlates, if that tells us more about somebody's prognosis? I think there's a number of pieces of information that we can glean here. And from the initial pilot study, we'll be able to do more targeted studies in the future. But I'm very excited for the potential of this technique.
That's great. The little that I've read about blood biopsies, just, in the public press, if you will, it really isn't clear to the public that it's not a one size fits all thing with blood biopsies, that, like what you're saying, that you need something very specific for sarcoma and reap the benefits of that for patients.
Yeah. I've spent a long time studying the molecular characteristics of different types of sarcomas and trying to put that together in order to design this technique accurately. And we probably won't be able to find 100% of the patients, but I think, and I'm hoping for greater than 90, 95%, if we design this right, this technique will be applicable to them.
Do you see a day when there's clinical trials, that all the biopsies done during the clinical trial, when you look down the road, would perhaps be all blood biopsies and no tissue biopsies? Or do you see in the foreseeable future, because it's so hard to see that far down the road, that the comparison is still really important?
I think in the right setting, it's possible that we could do that. If we see somebody come in with a large thigh mass that's quite concerning for a sarcoma, and we do the blood sample, and usually you can tell pretty obviously. If you see the cancer, it's pretty obvious, and a benign tumor wouldn't do that. Perhaps we could save the patient a biopsy in clinic. That's certainly possible. I don't think it's anywhere in the near future.
Right.
But I think as I said, there's over 80, over 100 different subtypes of sarcoma. We're I think moving to the point where, in addition to putting a pathological diagnosis on it in the classic characterization schemes that we've used before, we need to do molecular characterization, and we're building towards this. But perhaps we would give two tumors different names, but what if fundamentally on a genetic level they're doing the same thing to drive the malignancy? I think that if we get to that point, that could potentially help take the wide array of patients and start to narrow that down into certain groups, that this group might be more susceptible to this treatment, this group might be better treated this way. So we're getting there. That's essentially kind of personalized medicine.